We've just ticked over to 12:30, so I think we'll get started. So welcome everyone to today's webinar, Knowing Your Kidneys. Firstly, I just want to check that everyone can hear me okay. So if you could just let me know in the chat function whether you can hear me okay. Thanks, Teresa. Thanks, Jerry. That's wonderful. If you do have any tech issues during the webinar, then just pop that in the chat function as well, and I'll try and help you out. So my name is Kate. I'm the Community Engagement and Events Coordinator here at IMRI. I'd like to acknowledge the Dharawal people, the traditional custodians of the land on which IMRI sits. I'd also like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal people present on the webinar today. So today IMRI is bringing you information on how best to look after our kidneys and prevent disease. Our kidneys play a really important role in our body. Without kidney function, we would struggle to process toxins and eliminate waste, and this would have a devastating impact on our health. But kidneys don't always work as they are supposed to, and kidney disease can often go undetected. So this webinar, it will take a panel form and we'll look at why sometimes our kidneys don't work as well as they should, and what we can do to take control of our own health. So as I said earlier, our panel's here to answer your questions. And today we have Dr. Kelly Lambert, who is an advanced accredited practicing dietitian with qualifications in knowledge translation, health economics and management, and 2 decades of experience as a renal dietitian. Her research is intended to support people with kidney disease to live better lives and to progress the science about developing better patient education materials. So welcome, Kelly. We have Dr. Hisham Hassan, who is a staff specialist in nephrology at Wollongong Hospital. His research interests are clinical epidemiological research, pharmaceutical trials involving the renal unit within the Illawarra Shoalhaven Local Health District, and collaborating with UOW on epidemiological studies for chronic kidney disease. Welcome, Hisham. And we have Debbie, Debbie Pugh. Debbie has over 30 years of experience working in renal medicine, both in Australia and the UK. Debbie is currently the chronic kidney disease clinician nurse consultant for the Illawarra Shoalhaven Local Health District. Debbie helps to raise awareness of chronic kidney disease in the community and general practice, and is the link between primary care and nephrology and the nephrology team at ISID. So welcome, Debbie. As I mentioned a moment ago, our panelists want to hear from you. This is an interactive webinar, so please make use of that chat and Q&A function as the webinar progresses. We do have a specific Q&A section at the end of the webinar, but if something comes up while the webinar is progressing, I'll definitely answer that question there and then. And just very quickly, for those of you who don't know, the Illawarra Health and Medical Research Institute, better known as IMRI, is a not-for-profit charity that supports health and medical researchers in the Illawarra Shoalhaven region. Our goal is to bring scientists, researchers and health professionals together to solve our greatest health challenges through research. And our scientists are working really hard to find ways to prevent and treat diseases such as cancer, diabetes, mental health and dementia, to name just a few. So I think we'll jump straight into the webinar now. Kelly, can you tell us a little bit about the symptoms of chronic kidney disease?
Well, I thought we might start first with the poll, Kate. We might get people to warm up their brains first. So how about before I tell them, we might actually put that poll up. So the question is, what are the symptoms of chronic kidney disease? And it should be appearing now.
Everyone should be able to see that.
So is it pain in the chest? There may be none, change in vision or tingling in the legs.
Give you a few more seconds to answer that question. All right. That's 60% of you. Are there any other answers out there? Anyone else want to have a stab at what the symptoms of chronic kidney disease are? All right. Let's stop there. So we'll end that poll.
Yep.
Kelly, can you see the answer?
No, I can't see them. Yep.
So nobody answered pain in the chest. 7% of you answered change in vision. 7% answered tingling in the legs, and a whopping 85% of you answered with there may be none, there may be no symptoms whatsoever.
Correct. So that's good. That's a good part for us to start with, because there may be no symptoms in the early stages. So what I'd like to do now is I'd like to ask Hisham, who's the specialist in chronic kidney disease, to ask him some questions. So let's start at the start, Hisham. Can you tell me a little bit about kidney disease, chronic kidney disease specifically? So what is it?
Thank you, Kelly, for this question, and welcome for everyone who's joining us. Look, this term, chronic kidney disease, actually took us as doctors many years to get to. It's always changing, it's always improving, and we've always been updating it. Even the last number of years, there's been an update. But just to break it down to its component, to give a bit of history. So disease is pretty much explaining that this is a disease process. In the past, we used to think that as people age, kidney function goes down, and that's normal, but that's not true. We now know that if the kidney function is going down, even with age, there could be a disease process in the background, and it should be treated as a disease, not a normal physiological change. Kidney explains that we're not talking about bone or liver, it is about the kidney. And even that had a lot of discussions in the past. We used to call it chronic renal disease. It used to be called nephrological diseases. And then I think up to 2 years ago, there was this big meeting with a lot of patients who said, look, the term renal, we don't understand it. It confuses us. Can we just use one term? So that's where it was decided and updated to kidney. Chronic comes from the definition that this is a chronic problem. It's not something which might reverse or get better. We each have 2 kidneys. In total, we have 1 million functional units in each kidney, which is responsible for filtering. If you get damage for these functional units, they don't get better. They don't regenerate or duplicate or grow back in some way. It's permanent. So if there is a process in the background causing kidney damage, it's going to continue going there until either we reverse it or stop it or figure it out. So that's where the term chronic comes from. And that's where eventually we settled into a definition of chronic kidney disease to hopefully explain this and to give a bit of knowledge behind it.
And so that's very important that you mentioned there's most likely permanent damage. So how is it diagnosed then?
So for us to diagnose chronic kidney disease, you need to have either a structural abnormality or a functional abnormality. So there's 2 tests we do to look into them. We do a blood test, and this is a very loose way of trying to look at the function of the kidney, how much toxins in the blood, and how that translates to percentage kidney function. It's not a great test, but it's the best, quickest test that we have, and it's very good over time to give us trend. So this gives us the functional component. For the structural component, we look at the urine test. So we take a small urine sample, we send it to the lab to see if there's any protein in the urine. Kidney is a big filter. It's supposed to filter out the urine and keep into the body the red cells and the protein. When you get damage at a microscopic level, you get holes. The more holes you have, the more protein leaks through, and that shows up in the urine. So that tells us if there's any structural damage in the filtering component, the protein in the urine. These are the kind of 2 tests that we do. These are the screening tests, as we like to call it, which we kind of recommend people and GPs to do annually or semi-annually or every 2 years, depending on the risk groups. But based on the blood test and the urine test, at least that gives us an indication, is there a chronic kidney disease? Is there a kidney problem? Do we need to take this with further testing?
And for the audience members out there who may want to ask, say their doctor about their kidney function, what's the name of the test and what are they going to ask them?
So I think Debbie has done a lot of work regarding this, talking to GPs and making sure they do the right test at the right time. So I'll let her go into more details later on. But the main test is the blood test, the kidney, the creatinine, the eGFR, and the other one is the urine protein creatinine ratio. Talk about this a bit more later on. Discuss about GPs and screening. Yeah.
So can you tell me then a little bit about maybe symptoms if you have chronic kidney disease?
So symptoms is the biggest problem, isn't it? And that's why we had it as a poll question early on. The biggest symptom is no symptom. Kidney has big reserves. You might have progressive disease in the background, and you won't feel you have a problem until you're down to 30% or 20%. So you might lose close to 70, 80% kidney function before we even start to notice there's a problem. When symptoms do come, they are very unspecific. So it's not like heart disease where you have chest pain and the first thing you think of, I have a heart problem, I'm going straight to a cardiologist. Or you have breathing difficulties and you're thinking, is this a respiratory problem? You might feel tired, which is what everyone feels, I guess, these days with COVID lockdowns and staying at home. Fatigued, loss of appetite, very unspecific, doesn't really pinpoint. Some people start getting an itch. Some people start noticing they have swollen legs, or the legs are a bit more swollen as the day goes by. But fairly unspecific. And when they do come, it is later on in the process. It's not early on, which is unfortunate.
So why is it important to know if you have kidney disease or not? What's the problem with leaving it until those late stages?
If we can figure out why the kidneys are going down with time, if we identify the risk factors, we can treat it. We can delay progression. We can even stop progression. And even early on, we can even reverse it. And that comes down to why we'd like to screen people and try to detect it early and move in quickly and do something about it. And the silent nature is the concern. The other thing is that 10% of the population will have chronic kidney disease. So it is a large proportion of the population who might not know they have it. I think the biggest problem we have is that worldwide there's 850 million people with chronic kidney disease. 90% won't know they have it. It's only the 10% who are aware of it and get treated, who have a delay in progression, or who end up kind of halting it, getting worse over time.
So can you describe for me then who the people might be that would be at risk of having kidney disease?
The main 65% of the causes of kidney disease is diabetes and blood pressure. And that brings us back to the same problem as chronic kidney disease. Most people who are type 2 diabetics and who have high blood pressure have no symptoms as well. They don't have a problem, they feel well, they go to the GP, they get told you have a high blood pressure, they're given medications, they give them side effects, all of a sudden they have to remember taking these medications. So that's one of the problems. We recommend yearly screening tests for people who are considered at risk. So these are the people who have type 2 diabetes or any diabetes, people with high blood pressure, those with heart disease, those who have a history of kidney disease in the past. And there are some ethnic minorities who are at a higher risk of chronic kidney disease as well, such as the native population, the Australian native populations. These are the ones we'd also recommend screening tests for once every year. Otherwise, it's once every 2 years for people who are more than 50 and more than 60 years old, just to keep an eye on it.
Debbie, is there anything you wanted to add to those questions that I just asked Hisham?
No, I just thought I'd clarify what you were saying about the tests that they ask their GP to do. So it's just called a kidney health check. And as Hisham said, it involves a blood test, a urine test looking at the amount of protein passed, and also a blood pressure check. And as you were saying, this disease is a silent disease, and people often don't get the symptoms till very late. So it is often about the patients being proactive, talking to their GP if they have those risk factors, and actually asking to have a kidney health check.
Yeah, thank you. Over to you, Kate.
Lovely, gosh, so much to take in, really, and concerning around the fact that there aren't any symptoms. So it's good to know that we can all ask our GPs for that kidney health check. Thanks so much, both of you. So Kelly, I wonder whether you might be able to give us a little bit of information around the rates of kidney disease in our area. Worryingly, in the Illawarra, the average rate of kidney disease is around 19.5%, while the national average is only 10%. Do we know why this is?
No, we don't really, but it may be related to the fact that we have above average rates of obesity and diabetes and high blood pressure in the Illawarra. So that's a major driver of kidney disease. So it could be partly related to that. But there may be other environmental factors potentially that could contribute to that. You know, we are an industrialised area. There may be some specific pollutants that may be contributing to that as well. Both of those are things that Hisham and I are interested in looking at in terms of research. So that we don't really know, but we're looking into it, in short.
They are high rates. They do concern us as kidney physicians, hearing that we have the highest national average of chronic kidney disease in the nation. So we're trying to first confirm, is this true? Do we actually have 19% chronic kidney disease here? Or is it actually just a miscalculation, which does happen sometimes? They kind of project higher, but it's actually more towards the average. So we're hoping to clarify that.
Yeah.
I have noticed that people have raised their hands. Can I just mention, if you do have any questions, use the Q&A function and we'll get to those questions in the next part of the webinar. And if you want to share any experiences, then please feel free to put that in the chat function. Kelly, I wonder, could you tell us, is there any other research that's going into going on around kidney disease at the moment?
Yeah, we have got quite a lot actually. So one of the fortunate things we have in the Illawarra is that we have an excellent resource available at the University of Wollongong, which has enabled us to put together this very, very big data set, which looks at everybody who's been admitted to hospital in the Illawarra Shoalhaven Local Health District. And what Hisham and I and a number of other colleagues have done is taken that data set and are interrogating it with regards to lots of questions in regards to kidney disease. So I think perhaps we might ask Hisham to describe some of those projects since he's been a major driver of them. Hisham, would you like to describe some of those projects?
Yeah, it has been a big project and it's been 2 or 3 years in the making. Hopefully we'll have results soon. But like Kelly mentioned, it looks at everyone who ever presented or had a blood test in a local health district hospital. And it covers, I think, 65% of the population, mainly the older ones. So it covers most of the adult ones in the Illawarra. And we're hoping to confirm, do we actually have 19% chronic kidney disease, or is this an overestimation? And if we do we have, as I said, Illawarra is seen as a hotspot in Australia. It's a hotspot of chronic kidney disease. Do we have hotspots in this hotspots? Are there areas of more than higher? Are there some postal codes or certain clusters where there's more chronic kidney disease compared to others? And if that's the case, why is that? What are we missing in those areas, or what do we need to be doing? So there's a lot of work going on there. Of course, because when you have such a large data set, you can start to look at even other questions. What's the rate of diabetes, blood pressure? How do these relate with chronic kidney disease? How do we compare to the national average? How do these people do in the long term? But yeah, we're hoping maybe end of this year, next year, we can start answering these questions and then seeing what we need to do to kind of deal with it.
And can I just answer, I think it was one of the attendees' questions. I think he mentioned something about Cringilla having higher rates. Yes, that's true. When you look at some suburbs, particularly around Berkeley and Cringilla and Port Kembla and Warrawong, there's definitely higher crude rates of kidney disease than other suburbs. So that's kind of indicating what Hisham was saying, that there might be hotspots within our whole hotspot itself. So that's one of the major data sources we're looking at, but there are a number of other projects that are going on around the place with different populations who have kidney disease. So when we're looking at people who may have developed kidney disease as well as people that have existing kidney disease now. There's lots of research in this area.
There's a lot of work to do.
Yeah.
Do you know, like what sort of time frame are we looking at for this research to get some kind of answers?
Well, it took us 3 years to build up the database, and we're now almost towards the end. We're hoping by the end of the year, early next year, we can finally say, okay, we have an answer or we have numbers. We're close, aren't we?
Yes, we are. Yeah. I think part of the problem has been it actually takes days, if not weeks, to actually load all the data and put them together. It's that enormous. It requires lots of computing power. So it's not for lack of trying. It's just that it takes a lot of time to put all the pieces of the puzzle together. Yeah.
So putting the data together and then analysing that data once that job's done, which is, I mean, we all research, just it takes time. It's the nature.
It does. Building up the database is what took up the most time, making sure it's correct and that we have the right characteristics and it's structured the right way. That took the longest time. Once it's all cleaned up, then we can start processing, and that is much quicker. Yeah. We're almost there.
Yep.
And is this the CRISP work that you've been doing? That's what that's about?
So CRISP is the Centre for Health Research, Illawarra Shoalhaven Population, and that's a partly Illawarra Shoalhaven Local Health District and UOW funded centre. And that's been one of the major outcomes in terms of kidney disease, is to get that data set together. And from there, we've got years worth of projects that can come our way from that.
Yeah. So really dig down then, look at that data and actually see what's going on, and then needs to be done in the future to help reduce the incidences of kidney disease, chronic kidney disease.
Yep.
That's fantastic. Amazing work happening right here in our region. We should be so proud of the research that's happening right here on our doorstep. Thanks so much, Kelly and Hisham, for talking about that. Debbie, I just want to jump to you now, if I may. Can you just tell us a little bit about the work that you do out in the community, and is this what you're seeing, quite high kidney disease?
Yeah, I think like everyone said, the problem is because it is a silent disease that there seems to be, when I'm going around the community, and that actually a lack of knowledge about kidneys, what kidneys do, about chronic kidney disease, and about the test to diagnose it basically. People, when they go to their GP, as we've said, won't get the symptoms till very late. So they're not actually probably going to the GP with symptoms for chronic kidney disease. And so it really is about looking at our groups of patients that have the risk factors, especially the diabetes, high blood pressure, heart disease, family history of kidney disease, and people who are Aboriginal Torres Strait Islanders, to make sure that we're giving them the education and encouraging them to get the kidney health check with their GPs. And then this work that they're all doing with the CRISP project and seeing if we can identify any hotspots within our hotspot will be really important, to be able to put some education in those areas to try and increase that awareness. The GPs obviously look after many patients with many chronic diseases. They have limited time. Unfortunately, there isn't a Medicare item number actually for a kidney health check either. So often sort of the diagnosis is piggybacked onto the other diseases, and it's about working in collaboration with people in the diabetes department, cardiology, and those types of areas, which is where a lot of my work is, with education and awareness for their clients. So I think raising that awareness within the community is a big part of my role. And then I also work with GPs to sort of help to upskill them on kidney disease, and also to look at their practice software and to do some audits for patients that they have on their records that have got risk factors for chronic kidney disease, and trying to screen them.
So what do you think can be done to raise awareness? Is it webinars like this? I know there are a lot of there's a couple of organisations in New South Wales and Australia who are working to raise awareness of this. Would you like to see happen?
Yep. So I run some talks to people through the libraries in the local areas about raising awareness about looking after their kidneys. Webinars like this. Also, Kidney Health Australia have some great information that's Australian-based information. They also have a link on their website that people can actually take the kidney test, and so it will run them through a series of questions to see what their risk is, and also direct them to some information about kidney disease and the ways of slowing it down. And I guess as sort of Kelly and Hisham have hinted at, it's about preventative health, and it's about looking after ourselves, about self-management practices. And it's also about, what are we eating? What are we doing? Are we looking after our diabetes? Are we looking after our blood pressure? Because I think people don't realise the impact sometimes that having diabetes and having high blood pressure actually has on the kidneys. And so I think it's about making that link as well for them with their other diseases. And then it's also about looking at diet. And I know Kelly's going to talk a little bit about that shortly. I guess it's a bit like a car. We know what fuel we should put in it. And, we're not going to go and put diesel in an unleaded car because we can see the effect immediately. But I think sometimes we forget that, what fuel we're putting in our bodies also has an effect on our health. And so it's raising awareness in that area as well.
Thanks, Debbie. Thanks for that. Kelly, do you want to give us an idea about the things that we can do in terms of how we feel in our own bodies to prevent these kind of
Yep. I would love to. I could talk all day about that. So before I do anything, I'd just like to share some slides with some pictures. Diet's very important, yes, but so too is remembering not to smoke. I forgot to mention that before. So when it comes to people who may have existing kidney disease, what we want to do is to make sure that we reduce the workload on their kidneys. And the best way to do that is to make sure that they have less protein in their diet. So we're not saying a low protein diet. What we're talking about is reduced protein. So to put that in perspective, what that means is roughly the portion size of your hand should be what you consume in terms of eating meat or fish. And the reason that that's important is because when you digest meat or chicken or fish, the byproducts of that of digestion have to go through the kidneys and be filtered out. So by having a small portion size of protein-rich foods, what you're doing is actually reducing the workload of the kidney. So that's the first thing to take away. But there are some other aspects that are important from a dietary perspective. So we actually have lots of new important research coming out that shows that having protein that comes from a plant is actually more beneficial than protein that comes from an animal. So what that means is that we don't expect you to be vegetarian, but maybe you could have some legumes like lentils, nuts, kidney beans, chickpeas, other beans a couple of times a week instead of, or you would reduce the portion size of your meat and maybe add some beans to it. So for example, you might have mince and you might add some lentils to it perhaps. So that's actually including some more plant protein in your diet. And what that does is that actually reduces the amount of acids that are produced from the digestion process. And that's a really good thing for kidneys. That's actually protective for kidneys and it helps reduce the disease progression. So plant-based proteins. And just as an aside, there's actually a clinical trial going on at the moment at IMRI with my PhD student, Jordan. And what she's looking at there is a diet that has 30 different plant foods per week in it. So basically, you just have to tick off that you've eaten 30 different plant foods in a week. And what we know is that not only does that improve their bowel health, it also is expected to improve their kidney health. So just by including some more plants in the diet, we actually can have a really important positive effect on your kidney health. So that's where it comes to eating more fruits and vegetables. So this act alone of just having 2 pieces of fruit and 5 serves of vegetables a day is really powerful in terms of helping your kidneys. So when I talk about a serve, basically what I'm talking about there is a portion that's about the size of what you can fit in the palm of your hand. So that might be half a banana, it might be a small potato, it might be a couple of florets of broccoli. That's what a serve is. And so you need 2 serves of fruit and 5 serves of vegetables. Ideally different colours, because that helps provide you with lots of other positive effects from antioxidants and anthocyanins and all those sorts of things. So plant-based proteins and eat more fruits and vegetables. The other thing that's important is to think about where you get salt from, because salt alone increases your blood volume, and that means that your kidneys have to work harder and filter more. So a lot of people say to me, oh, I don't eat much salt, I don't add any salt at the table, but unfortunately that's not where most people get their salt from. It only accounts for 5 to 10% of people's salt intake. Where people get most of their salt from is from packaged foods. And unfortunately, people don't always know what they're looking for when it comes to salt in packaged foods. So essentially, any package that you look at should have, if you're wanting to follow a reduced salt diet, less than 120 milligrams of sodium per 100 grams. And so if you're eating the majority of your packaged foods with salt in that area, that range, then you're probably doing okay. But a typical example there might be cornflakes. Generally has 800 to 1,000 milligrams of sodium per 100 grams. So it's a very salty product, but people don't necessarily know that it tastes that salty. So just making a few simple swaps is really important in terms of salt.
Would you like me to share that poll now, or am I jumping the gun?
Yeah, why not? Let's have a look at that then. So in terms of salt, what category of foods or food products do you think Australians get most of their dietary salt from? So I told you it was packaged foods, but what type of packaged foods? When you're ready, Kate, you can tell us what people have thought.
Yeah, will do. Just give you a few more seconds, 5 seconds to answer that poll. And I worked out how to share the results now. Apologies for that beforehand.
That's all new technology. It's all good.
All right, I'll just end that now.
Let's have a look what people thought.
Their results. Can everyone see the results?
Excellent. So that is correct. Most Australians get most of their salt from processed meat. So this is things like ham, sausage, salami, bacon, Devon, cabanossi. Those kind of processed meats are very tasty, but very salty, unfortunately, and they're often staple foods in many people's diets. The things like chips and crisps are obviously salty to taste, but they don't make up the largest proportion of people's salt intake. So my takeaway message would be, have a look at the products that you have in your pantry and see what salt the sodium is per 100 grams and see if you can make a better swap at the supermarket. The final message I guess I wanted to pass on, or the second to final, was about what your plate should look like. So regardless of where you're from, whether you're Chinese, whether you're Indian, whether you're Australian, whether you're Mexican, basically half of your plate at each meal should consist of vegetables or salad, and a small portion should be protein, and a small portion, roughly a quarter of your plate, should be some kind of starch. So that could be couscous or rice or potato or pasta, could even be corn or sweet potato. And that's what a healthy balanced plate looks like in order to protect your kidneys. It's healthy generally, but it's especially healthy if you have unhealthy kidneys. Now, finally, I couldn't go past including this particular slide because it's a very common question. So what I'm referring to here is you should drink lots of water to help your kidneys. Now, the best analogy I can give is your kidneys are a bit like a sponge and they need to stay moist. So drinking water is the ideal drink, but you could also include diet soft drinks or fruit juice or milk as a source of fluid as well. Now, unfortunately, as your kidneys start to fail though, it's unhelpful to drink lots of fluid because that fluid doesn't get excreted and can therefore accumulate. So that advice of you need to drink lots of fluid to help your kidneys is correct to a certain point. But then as your kidneys start to not work so well, we have to switch our mindset and start restricting our fluid. So if you're not sure, you need to know how much you drink, you need to go and talk to your doctor or your nephrologist about what your kidney function is like. But essentially, if you're in the early stages, drinking lots of water is really helpful. Okay, I'll just stop sharing those slides with you, Kate.
Question.
Hopefully, no, you don't need to go vegan. I'm not recommending you going vegan. What I'm saying is including some extra plant-based protein in your diet is very helpful.
So can I ask, with obviously vegans don't eat eggs, for example, or dairy products, the protein that that our bodies process from animal products are not necessarily meat. Does that put stress on our kidneys as well?
So it's the same if it was milk or if it was eggs, that they're still animal-based proteins and they still generate a lot of byproducts that are negative in terms of the health of the kidneys. So plant-based proteins, as much as you can include, you don't have to go vegetarian, but that's a really beneficial thing.
To go vegetarian?
No, you don't need to. Just include more plant-based foods in your diet. Yeah.
Okay. And Barb has just asked, can you please repeat how much salt per 100?
Yes, happy to. So what you're looking for is the per 100 gram column, and you want to have a package that has less than 120 milligrams per 100 grams. Let me give you an example though. So bread, for example, might have something like 380 milligrams per 100 grams of sodium. So I'm not saying don't eat bread, but I'm saying of the foods that are probably not as nutritious as bread, make sure that they've got less sodium. Can I answer that question about protein powders as well that I've got here?
Oh, yeah.
So protein powders are bad, especially if you consume lots of them. So they do contribute to the effect on the kidneys in terms of what we call hyperfiltration. So if you're having a small amount of protein powders and that doesn't put you over your protein limit for the day, it's fine. But if you're pumping lots of them in, like lots of people do, if they're heavy exercises, it's still going to put lots of pressure on your kidneys. So it's a bad thing.
And sorry, you may have already mentioned this, but how would somebody work out what their protein limit is per day?
A dietitian could tell you, but a general rule would be if you're having a small portion size piece of meat and 4 slices of bread, a couple of serves at least of dairy products, that's all the protein you need in a day.
Even if you're quite active and exercise, that's all you need.
Yeah. It does vary according to body size. So if you're a very large, tall, muscular person, you need more than a small, frail, petite person. Yeah.
And I guess the message would be that if you are unsure and you want to make sure that you're getting the right amount of protein, not too little and not too much, go and see your GP or go and see a dietitian.
Yeah, go and see a dietitian and we can help you work that out very precisely.
Yeah.
Can I also answer some of those other questions? Is that okay?
Of course, I was just about to say we'll go to the Q&A section now. So Kelly, if you can see the questions if you'd like.
So Eloise has said, how much water should we have when you stay early stages? What does that mean? Okay, so if we're talking about, there's 5 stages of kidney disease, and if you're in the early stages, say such as stage 1, stage 2, even stage 3A, then having at least 2 litres a day of fluid, notice I'm not saying water, but fluid is actually not bad. It's when you start getting to stage 3B, so around 45% kidney function or less, that's when you're going to have problems with fluid accumulation. So you wouldn't be aiming for 2 litres of fluid a day. It might be a bit less. If you were stage 5, so very far down the track, you might only be allowed to drink 1,000 mils of fluid in a day. So that's the difference we're talking about. So early stages is generally stage 1 and 2, and maybe the start of the stage 3A group. Hopefully that answers your question. And I'm saying fluid, not water, because some people just can't drink that much water, and that's okay. It's about fluid. So it could include some tea, could include some coffee, some fruit juice, some milk. That's fine.
I find it more important for people to cut down their salt than to drink more water.
Yeah. Are there dietary recommendations for people who get recurrent kidney stones? Yes, there are. There's very specific guidelines for kidney stones, and Hisham's also an expert in kidney stones. The general rule for me would be, first, you need to find out the type of kidney stone, and second, drink more water, full stop, lots of it. Reduce your salt intake and reduce the amount of protein. They all contribute to the formation of kidney stones, but then depending on the type, there might also be some additional dietary advice to go on top of that. Hisham, would you like to add anything?
It's important to know the type of stone, because the diet might be contradictory depending on what the stone is.
Yep.
And stone formation is a complex process. Sometimes you have to really go upstream and see what is this person doing to get kidney stones. The kidneys are trying to fix a problem, and this problem results in a stone. So what's happening upstream? So that's where we go into the diet history or the occupation or the medications to figure it out. So it's hard to give a very general dietary recommendation for people with kidney stones. It's a very kind of coming down to the details and trying to dissect it out. So I agree with that, Kelly, yes.
Yep. There's a question here in the Q&A that says, are kidney stones linked to or a sign of kidney disease?
Let Hisham answer that one.
There is an association between kidney stones and the future risk of kidney disease. Yes, it's a small risk. Most people with kidney disease will still come down to diabetes, blood pressure, or pretty much, other risk factors. But there's a small increased risk, so we do like to keep an eye on them.
So your message would be, perhaps if somebody has experienced kidney stones in the past, and make sure that when they go and see their GP that they have that kidney.
The standard screening test that Debbie mentioned, every 1 or 2 years, should be included, definitely.
Great, thank you. Let's have a look at the questions then. So, I mean, we've covered some of them already. Melissa wants to know, just in case it doesn't get covered, and I might ask one of you to just elaborate on the question. She's asked to know if there's anything dietary known to cause a worrying dip in GFR over a relatively short period of weeks, say a couple of months, that bounces back once dietary changes are made. She's thinking of things such as supplements.
Yep.
What's GFR, firstly?
GFR refers to the filtration rate of the kidney. So that's partly what Hisham's referring to in terms of one of the blood tests. It's something that we estimate how much is in the blood. What was the question again? Sorry, I just forgot what you asked me.
Is there's anything dietary known to cause a dip in GFR over a short period of time?
There's lots of reasons why your GFR might dip, and Hisham could maybe elaborate on some of the other ones. But yes, a very large protein intake the night before you have a test can sometimes cause a drop in your GFR, because you've got lots of those byproducts needing to be filtered out. So the protein intake can cause a temporary drop. So I think that they mentioned they might have ceased supplements, for example. So that could sometimes remove that effect, and you might see it temporarily go back up. Yeah.
Okay. Hisham, did you want to add anything to that?
No, I do exactly what Kelly said. It's not a very accurate test, and there's sometimes when they do fluctuate a bit. So that's why if it's coming down, we do like to repeat it and keep an eye on it. High protein, as mentioned, will cause more degradation product, which will result in a falsely elevated creatinine, which results in a lower eGFR. It's a complex process. It's not a great blood test, but it's the best that we have. There are medications which will also play with the eGFR. So people who go on non-steroidal anti-inflammatories, ibuprofen, Nurofen, that'll put pressure on the kidneys and bring up the creatinine. Some antibiotics do it as well, some blood pressure tablets. And that all comes down into taking the person as a whole, not just individual blood tests or components. So yeah.
Can I also add too, I've also seen people experience a temporary drop in their GFR when they've undertaken really heavy CrossFit training. So they've actually built up lots of muscle mass very quickly. And that's a that's going to temporarily cause a rise in your creatinine level, and that's what is going to be reflected in a lower GFR, which is your reflection of your kidney function. So I've had quite a few people who've done CrossFit who've then had to go and see a nephrologist because they were concerned there might be something driving their kidney function down, but really it was just a reflection of a big buildup of muscle in a very short period of time.
Yeah, I've seen that a few times as well, Kelly, and especially if someone's dehydrated after they've done that before they've had a blood test. So yeah, it can all influence it.
I'm not saying don't exercise though, please do. That's really good for you.
Yeah, but there are times when you will get this false dip, and it's important to have a doctor look at it and clarify it. I have patients who lose a lot of weight very quickly, and their eGFR will dip. And I think that's because when you lose weight, you're burning up a lot of the muscles and the fat, and all these byproducts have to be filtered by the kidney. But for a while, they do go up, which reflects in lower kidney function. But once your weight stops going down, it recovers back up again. So we just keep an eye on it, and we keep pushing for weight loss and things like that. So it is a complex interplay.
So there's a question here. What is the ideal level of, is it Christine?
Creatinine.
Oh, is that what that, okay. I mean, that's quite a difficult question to answer, I guess, because it would be on an individual basis. Person asking the question has said age late 50s.
If it's creatinine, I can't quite see the question. There is,
yeah, in the Q&A function there.
There is a normal range of normally less than 110, but that's not a very precise measure of kidney function either. So Hisham, do you want to add something to that?
When we look at kidneys, we don't look at one measure. So someone old might have a slightly high creatinine, but if they have no protein in the urine, no blood pressure, no diabetes, everything else the kidney is supposed to do, like controlling the potassium, calcium, phosphate, hemoglobin, iron, everything else is normal, then I wouldn't be concerned. And if the blood test comes back stable over time, then I'm not worried. So it's a lot of measures that we look at. It's not one single thing. We do the creatinine and the urine as a screening test, just to highlight is there a problem. And if they come back abnormal, then we do some more tests to see what's happening. But a slightly high creatinine by itself, in the absence of everything else, with no risk factors, which is unchanged over time, is something I would say not to be concerned about and just to monitor.
And you mentioned the results over time. Does that mean that one test result doesn't necessarily mean much in isolation, that you have to have several tests over a period of time to get a really true idea of what's going on inside someone's body?
Sometimes yes, sometimes yes. The eGFR for me is a bit like the blood pressure. Sometimes it's a bit high, a bit low, a bit high, and you need to do a few tests over a period of time to see, is there a trend? Is it high, low, but stable on average, or is there a bit of slow decline over time? So that's something we do need to do. It's not the best test, as I keep mentioning. It's like rough estimate, and sometimes it's a bit off in the way it estimates. And that's why we don't use this one measure as the definition. We have to take a step back and look at the whole picture.
Yeah.
Can I just add there that obviously when a patient has a kidney health check with their GP, as you were saying, one test result on its own in isolation won't say that they've got chronic kidney disease. If it's an abnormal test result, it will be repeated, and then they will do some investigations to see what the cause is. If the kidney function level is abnormal over a period of time of greater than 3 months with some investigations done, that's when they would get the diagnosis of chronic kidney disease. But one test result on its own won't mean that they've got chronic kidney disease. And I think it's also important that this is coded in their GP medical record, so that we can, as Hisham was saying, follow that trend of their blood results over a period of time to see where they're at, and what effect sometimes when we put medications has on that blood result as well.
Thanks, Debbie. Someone has asked about a family history of kidney disease. Should somebody whose family, if there is kidney disease in the family, should they have more routine health checks?
So according to Kidney Health Australia guidelines, I think family history is one of the risk factors, like diabetes and blood pressure, which would say that you need to have the check every year, not every 2 years. Yeah.
Okay, thanks. And someone here wants to know, they've just put, how about alcohol consumption? So I guess, how does alcohol consumption impact our kidney health?
Alcohol increases blood pressure, which is a problem because that puts a strain on the kidneys. So we want people to enjoy alcohol, but consume it in the amounts that we recommended for the healthy population. So 2 standard drinks a day with a few days of alcohol-free days per week. What people need to know is what a standard drink is, though. So it's not as much as people think it is. Yeah.
It's like salt.
Yeah. Yeah. So it's not banned, even when you're at stage 5. It's just about limiting the amount that you have. Yeah. Can I ask Hisham to answer that question about the paracetamol? That's an important one.
Please, yeah. Hisham, have you got that? So I think it's Shelley. I can't read the name, but I have renal failure, and I have been told the best painkillers I can take are paracetamol as processed by the liver rather than the kidneys. Are there any over-the-counter medications that we should avoid to avoid putting extra pressure on the kidneys?
Look, pain is a complex thing, isn't it? It depends on why you have the pain, where is the pain, what's causing the pain. There's actually pain specialists who would go down and try to see what's the best way to try to relieve it. When it comes down to kidneys, we try to avoid the what we call the NSAIDs, non-steroidal anti-inflammatories, which is the ibuprofen, Nurofen. These are the ones which do put pressure on the kidneys. They cause the kidneys to kind of be a bit on the hard side and retain a bit more salt, and the blood pressure goes up. So kidneys don't like them on the long term. If someone has a headache and they want to take an ibuprofen once a month, that's fine. But we worry about the chronic use, the one who's taking it every day or 2 tablets a day for a prolonged period of time. Paracetamol certainly doesn't have any effect on the kidneys, and it is not as good as some of the other ones. For these kind of questions, it's hard to give a very general answer for an individual person. It's more of a general advice is avoid non-steroidals, and you need to kind of speak to a specialist to see what's the best pain tablet for your particular case.
Yeah, good advice. Thanks, Hisham. Debbie, Kelly, did you want to add anything to that?
No, that's definitely Hisham's specialty. Yep.
Okay.
And I guess if you are buying over-the-counter medications and you do have kidney disease, it is always a good advice to talk to the pharmacist when you're buying those for that reason.
Yeah, good reminder. Thanks, Debbie. Peter wants to know, has the current COVID pandemic had an effect on kidney functions at all? I'm not quite sure. I wonder whether you mean who has been diagnosed with COVID, whether that might have an impact on kidney function. Does anyone have an answer to that question, or is that still being looked at, being the relative newness of the disease?
Well, I think people with chronic kidney disease are at risk of more severe COVID manifestations of the virus. Luckily, in Australia, our numbers are still, I think, low. We haven't had any patient. I've never seen a patient here with COVID yet in Illawarra with chronic kidney disease. And hopefully, it stays that way. So, yeah, vaccinate.
And Liz wants to know. We've already talked about how some medications can affect kidney function. Can steroids impact the function of your kidneys?
Steroids may make your kidneys look worse than they are. So if you start steroids and some of the kidney functions increase a bit, that's fine. Usually when you bring the steroids down, it should go back up to normal. That's because steroids break down the muscle and fat. It's a catabolic agent, so it breaks down a lot of the muscles and fat, which is similar to the weight loss we discussed previously, that you get more of these things which the kidneys try to filter out. So it's if you need the steroids, definitely be on it. Yeah.
Okay. What else have we got here? It's a lot of the same that we've already talked about. Let me just check out any other additional questions.
Can I answer that one from Alice? Is that okay?
Yeah, please.
So Alice has asked, is salt control a more important focus for kidney health, as overconsumption of protein may be harder to achieve when following a well-balanced diet? It's kind of a triple-pronged approach. We want to reduce salt, but protein also plays a part too, and so does having inadequate fruits and vegetables. So it's not a matter of choosing one over the other, but trying to achieve all three of those things in order to protect your kidneys. And if a person's following the Australian Guide to Healthy Eating, so if they're having a portion size of meat or chicken or fish that's the size of their palm, they have 3 to 4 serves of dairy products a day, have 4 serves of bread, you're not going to be overdoing it on protein. You'd actually meet your protein targets there. So if you're following a healthy diet, you won't eat too much protein. Hopefully that answers your question, Alice.
We've got an anonymous question here asking whether there's any data around BMIs and occupations for those identified as having chronic kidney disease from the test. So I guess perhaps you're thinking those people who have more sedentary occupations, and perhaps therefore a higher BMI might have higher rates of kidney disease. Is there any data around that?
There is on BMI. I don't know if Lily would like to answer that one.
Being overweight and obese is associated with declining kidney function over time. So we want people to achieve an ideal body weight, a healthy body weight if they can, but even 5 to 10% weight loss is actually really good for your overall health. So you may never get back to the weight you were when you were 40, but being 5 to 10 kilos, maybe lighter, might be okay. Yeah, you will see an improvement. I wasn't sure if that was referring to the CRISP data set either, because we do actually have information on BMI, so body mass index, for some participants in our data set. So we may be able to explore that association a little bit in our own data set locally. We don't have anything on occupation though, unfortunately.
No.
Yeah. Can I maybe ask Hisham to answer the one about cystatin C?
Yeah, please do, yeah. So the question is, what is the new cystatin C test? Are we doing any research in this area?
So cystatin C is hopefully going to replace the current blood test we use, which, as I mentioned, is not that great. It does have its flaws and it has this large margin error. So they're trying to find a better one to use. Cystatin C is one of the possible identifiers that we can focus on. It is still a research modality. That's the problem. And it's giving us the same information that we're currently using, just a bit more accurate. So we're not there yet. It's going to take a number of years. It doesn't change what we're doing now. So it's not a test that's going to impact how we do things. It's going to be the same thing that we're doing, but maybe slightly more accurate than before.
Yeah. So in addition to what's already happening.
We're hoping it'll replace the eGFR one, the creatinine. Right. Yeah, because the creatinine does have its large uncertainty in it. Which, as we discussed, you might be losing weight, it'll go up, or you might be taking a non-steroidal, or you might be eating more protein. So it's not that accurate in that measure. So we're hoping cystatin C won't be affected that much by these things. But it doesn't change the way we practice or the way we approach it. It doesn't.
And just the last question here, Rob said, if you were exposed to lead dust 30 years ago, but there's no evidence of lead poisoning now, could this be a reason for kidney disease or dysfunction if there's no other risk factors present? Is that a question that?
That's a Hisham question, if anyone, not mine. Yeah.
Trying to think how to. There is some evidence about kind of occupational exposures or pollutions on chronic kidney disease, but by far the biggest cause of kidney disease continues to be diabetes, blood pressure, heart disease. All these risk factors that we did mention. I think people who do have environmental exposures might be more prone, but they still need to have these risk factors in the background. I mean, if you had lead exposure in the past and you have chronic kidney disease now, it's good to make sure that there's nothing else causing the chronic kidney disease before we settle on the lead as a cause of it.
Thanks, Hisham. Okay, well, I think we'll start wrapping up now, but I just wanted to ask a quick question around what impacts perhaps have been from COVID on research that's been able to take place. Have you been impacted at all?
I'll let Kelly answer that because she struggled a lot.
Yes, from me. You name a research study I've got and it's been impacted by COVID. The biggest one I've been disappointed about has been I received some grant funding to conduct an exercise program for people who've had a kidney transplant. And I haven't been able to get that off the ground because every time we go to start it, COVID little outbreaks happen. And so it's a really important study because we're trying to demonstrate that this new form of exercise might actually have some benefits for people who've had a kidney transplant. So if and when we ever come out of lockdown, that will be one of my priorities. But even like the study I was talking about before with Jordan, where we had people coming in for the plant-based diet of 30 different plant foods a week, we stopped and started. Now we're nearly ready to finish. And so hopefully we'll get that across the line by the end of the month. IMRI's been good actually in letting us continue our research through lots of different precautions that we're taking, but it's been terrible. And yes, the uni gym is closed. Yeah. Everything. Yeah.
That is the benefit of IMRI being independent, not-for-profit health and medical research institute means that we are under different guidelines. So some research projects have been able to continue, which is really fantastic news. Kelly, if people in the future, when things do start to return to normal again, if they want to get involved in some trials or any research that's happening, is there a way that they can do that or find out about what's going on?
Look, there's probably a couple of avenues. So the IMRI website does often have advertisements for studies that are going on. So that would be a good place to have a look. I think in future we will try and use the IMRI Facebook avenue more to advertise some of our studies so that it can reach a broader cross-section of people in the Illawarra. We also have staff at the renal unit who are responsible for conducting research too. So if you're already under the care of a nephrologist, you may be informed about research that's going on via that mechanism as well. And perhaps Debbie or Hisham might want to comment on that potential.
I was just going to say that there is on the webpage for the Illawarra Shorehaven Renal Unit, there is a link about the research projects that are underway and contact numbers. So if anyone is interested, or again, they could ask anyone in the renal clinic if they're a patient of the renal clinic or the nephrologist. And yeah, it's really great to be involved in the research.
Yeah. We made it easy to find. So if you Google renal, Illawarra, Wollongong research, it should be on the top or one or two kind of hits. And then it shows what we're doing, and yeah, it's a bit more information there.
I'll do a follow-up email to everybody post the webinar, and I'll include as many links as I can and use information that we've discussed today. I just wanted to finish off. Can I just jump to each of you and just to give me, or to give our audience some key takeaways that you think, if they don't remember anything else from this webinar, what would you like our audience to take away with them? Debbie, perhaps would you like to start?
Yep, by all means. I guess my key take-home message would be that if you have any of the risk factors, then talk to your GP about a kidney health check. So especially the diabetes, heart disease, family history of kidney disease, Aboriginal Torres Strait Islanders. Yeah, talk to your GP and get a kidney health check.
Thank you, Debbie. Hisham?
90% of people with chronic kidney disease have no symptoms. We have how many? 65 participants. So 10%, that means 6 people have chronic kidney disease. 5 of them don't know they have it.
Go and see your doctor. Get the tests that are available and keep an eye on it. Lovely, thanks, Hisham. And Kelly, finally to you, any takeaways for our audience?
Small portions of meat, chicken and fish. Know how much salt you're consuming by looking at food packages. Eat more plants or food that come from plants. And I was thinking about that going, but people might say alcohol, but I mean fruits, vegetables, nuts, grain, legumes, those sorts of things. They're all good for you, and having more of them in your diet is going to be good for your kidneys.
Yeah, wonderful. All right, well, I think we'll finish there. I want to say a huge thank you to our audience for being, for asking all those questions and for your engagement and interaction. It's a really great way to hold these events. We're really grateful for your interaction. And of course, thank you so much to Hisham, Debbie and Kelly for sparing us an hour of their time to talk to us all and share their work with us. And help to inform us on what we can do to take control of our own health and reduce our chances, our risks of kidney disease. I will be sharing a recording of this webinar on the IMRI webpage, and also in that follow-up email I mentioned earlier. So keep an eye out for that. We do have some more webinars coming up. In 2 weeks' time, it's National Science Week. So we'll be holding a webinar on pain management and what is pain and how best to deal with it. Huntington's disease, what it is, who's affected by it, and the research that's been done into it. And another one, sorry, on hormones, health, and human connection. I know we're all lacking a little bit of human connection and connection at the moment. So if that is something that you think might be interesting for you, then please register for that. You can do that on our webpage, which is www.imri.org.au. As Kelly mentioned, there's also lots of information on the different trials, clinical trials that we do. And of course, we keep information on there of all the research, all the affiliated researchers that we have at IMRI, and of course, all the different events that we have coming up. Slightly disrupted by COVID, but we are hoping to have an open day. It was scheduled for the 30th of June, so we were just too late for the restrictions this year for the COVID lockdown, but we're hoping to do that very early next year, so we'll keep you up to date with that. If you haven't already, I do encourage you to register or subscribe to our IMRI newsletter. It only comes out every other month, just to let you know about the type of research that is happening, any trials that are taking place should you want to get involved in that, and also any events that we have coming up. You can find that on our imri.org.au webpage as well, under news, or support us, one of the two. But have a look around, it's a great website, lots of information about who we are and what we do. There is a very, very short survey at the end of this webinar. If you do have a couple of minutes, there's only 3 questions, and please do take the time to fill this out. We want to make sure that we're delivering information that is relevant and interesting to you, our community. So please let us know what you think. So once again, thank you so much to everybody involved, our audience and our panelists, and we look forward to seeing you at the next webinar. Thanks everyone, bye.
Thanks, Kate. Bye, Hisham.
Bye,
Bye, Deb.
bye.
Bye, Deb.
Bye, everyone.
See you.
Thank you.